Mike Gibson, Steve Juraschek, and we're talking about the use of a DASH diet in terms of grocery shopping to improve blood pressure in those people who have high blood pressure. Talk to us a little bit about the GoFresh treatment trial, Stephen.
Well, thank you so much for speaking to me about our study today. So this was a trial focused on Black families who lived in Boston communities where there was a lower concentration of grocery stores, and the communities were characterized by lower median family income. And we were looking at access to healthy foods among individuals who had been identified as having hypertension and were actively being treated to see if access to the groceries, patterned after the DASH diet, could improve blood pressure and related cardiometabolic risk factors. Our thought was that hypertension disproportionately affects Black populations. Black populations had been very responsive to the DASH diet, DASH pattern of interventions in prior research. And many Black adults are medicated and treated for hypertension, and yet prior feeding studies around DASH were performed in individuals without hypertension treatment. So GoFreshRx was really focused on can we, by improving access to healthy groceries, lower blood pressure in this medicated Black population?
Tell us a little bit about the design and what you found.
Yeah, so we randomized folks to either a monthly stipend of $500 as our reference group over a 3-month period. So there were 3 stipends. Or folks were randomized to a weekly telehealth session with a research dietitian who would help them order groceries from a local grocery store. We used Amazon Fresh or Instacart. The groceries would be patterned after the DASH diet, delivered to people's homes, and then folks got a brief didactic about healthy eating, nutrition, interpreting nutrition facts, ordering groceries on a budget, preserving groceries to prevent perishability, and so some very practical tools to incorporate the groceries into their daily life. The groceries were ordered following a number of basic principles. First, the emphasis was on preparing meals at home, so not eating meals at home and seasoning without salt. Another important principle was to maintain, we used the nutrient facts that were available with all the groceries to target a pattern that was the potassium to sodium ratio was 2 to 1. And so that was really key, targeting blood pressure. Then we also made sure that all of the groceries, so across the grocery list, the proportion of calories from saturated fat was less than 7%. And then the last feature of emphasis was that the pattern distribution of grocery items mirrored DASH. So there was an emphasis on whole grains, fruits and vegetables, low-fat dairy, fat-free dairy, and then lean meats, and then restriction in sweets and sugary beverages. And so with that pattern and those kinds of basic principles, we ordered groceries, enough to feed the index individual as well as all family members at dinner time, up to 5 additional folks, and they were delivered on a weekly basis over 12 weeks. Our primary outcome was systolic blood pressure measured in an office clinic-like setting, and we looked at blood pressure before randomization and after randomization. We also looked at 24-hour urine and then had labs to look at cholesterol, hemoglobin A1C, and we measured body weight as well.
And what did you see?
So the intervention of those assigned to the groceries, they had a pre-post reduction in systolic blood pressure of 7 millimeters of mercury, while those assigned the stipend was unrestricted, they could spend as they would, had a pre-post non-significant difference of 2 millimeters of mercury. And so the net comparison, or primary contrast at 3 months, was a reduction of 5 millimeters of mercury between the DASH groceries and the stipend group. We further, secondarily, allowed people to kind of go off of active intervention. We followed them and observed whether or not they could continue to apply what they learned on their own during this observation period. And then over the ensuing 3 months, what we found is that the group with the stipend had an increase in their blood pressure, slightly going back towards baseline. But the group that with the groceries actually were able to maintain their blood pressure lower over the ensuing 3 months when they were on their own, such that there was a net a significant reduction in millimeters of mercury of 4.4 from 6 months compared to baseline, which we are quite excited and encouraged to see.
Well, 4 to 7% reductions in blood pressure are quite meaningful in terms of morbidity and mortality. Congratulations, Stephen. That's really fascinating. And what are you going to do to implement this?
Yeah, so this trial comes was conducted independently of a previous trial we shared earlier in the year in an unmedicated population where, when the active intervention was removed, there was more of a return back to baseline, and there was a question about, well, the groceries could be somewhat expensive if it only works when the groceries are delivered. Is this something that can really be sustained? And we're kind of grappling with that. In the treated population, we're seeing that there was maintenance of the intervention. And we really think that people were able to, even though the access issues and some of the barriers in the communities persisted, people were able to take advantage of what they learned, sort of the tailored grocery list for their families. They worked it out with a dietitian. They were able to take those grocery lists and continue with them beyond the intervention phase. And so we think that this is sort of a lot more cost effective, especially if the intervention could be extended, or benefits could be extended further beyond the 6 month period. So we're excited by the prospect that even an intensive 3 month period could be something that people could really benefit from for longer in the future. I think further work needs to be done to kind of evaluate, well, could we focus on a subset of groceries, maybe really the fruits and vegetables or the high potassium foods? Could we focus on a less intensive period? Do we need 12 weeks? Could we do it in 4 weeks? This is something we're exploring right now through a follow-up study in Tennessee, Georgia, and Florida, a 4 week intervention. So
Very important public health implications. Congratulations, Stephen. Great job.
thank you so much. We really appreciate the opportunity to share our work.
And thanks for all of you for joining us here today, live from ACC 2026.